Hi, everybody. I'm Alanna. I'm one of the other fellows here in Toronto at University Health Network and Mount Sinai. Today, Dr. Warren and I will discuss BPA, or balloon pulmonary angioplasty, and the treatment of CTEPH. We have no disclosures. So the agenda will review a pulmonary embolism case, then discuss CTEPH and BPA in the role of CTEPH. We'll review BPA case examples and discuss complications associated with BPA, and then we'll go through any questions that anybody has. So we'll start off with a case example about a pulmonary embolism, as it is the inciting factor for CTEPH, and we can't really talk about BPA and CTEPH without talking about pulmonary embolism. So here we have a case of a 56-year-old male with a history of a recent left hip fracture requiring operation. During induction, the patient was found to be unstable. They continued and completed the operation, and then a workup for instability was carried out as the patient remained hemodynamically unstable and required norepinephrine postoperatively. So CT was performed at this time and demonstrated bilateral pulmonary emboli, as we can see here, these filling defects, as well as filling defect within the right atrium. It's suspected to be clot in transit, of course. So here we can see a large bore aspiration as pulmonary thrombectomy was carried out by the interventional radiology team. And note the large bore of this aspiration catheter in this. And here we have the images of all the clot that was pulled out from the right atrium. So that was the clot that we saw in that pulmonary embolism scan, and managed to pull that all out. So here in the interventional suite, this is just a quick image of the pre-thrombectomy DSA. So you can see the clot here just in the region of the pigtail catheter tip, and sort of the decreased flow here out to the periphery. And then after the aspiration here, sorry, it's a little bit quick, this image. You see increased flow through the periphery of the lung there, and resolution of that thrombus. So what is pulmonary embolism? Pulmonary embolism is partial or complete occlusion of the pulmonary arteries with a 1 in 1,000 incidence. Risk factors include hypercoagulable states, recent surgery, malignancy, trauma, prolonged immobility in flights and car rides, things like such, and clotting disorders, hormone therapy, pregnancy, and infection. Treatment of PE includes anticoagulation, thrombolysis, either systemic or catheter-directed, and thrombectomy, which could be percutaneous by the interventional team or surgical and open. Complications of PE acutely include pulmonary infarct, cardiac failure, and death, and chronically include CTEPH and CTED, dyspnea, and postpulmonary embolism syndrome. So with that, I'll move on to talking about chronic thromboembolic pulmonary hypertension, or CTEPH. So essentially, after pulmonary embolism, this is remodeling of the pulmonary artery, which results in obstruction of the pulmonary arteries, elevated pulmonary arterial pressures, right heart strain, and then eventually leading to right heart failure, and oftentimes then death if it's left untreated. It significantly affects patients' quality of life. The dyspnea is really quite limiting. Patients are unable to do the typical things we all would, like walk your dog, play with your kids or your grandkids, and it really does quite affect patients' quality of life to a negative advantage. CTEPH, it's rare, but it's serious, and it does reduce life expectancy. So talking a little bit about balloon pulmonary angioplasty and it itself as a procedure and what the workup involves. So multidisciplinary teams are very involved in these patients, typically with a CTEPH clinic. These patients are discussed at multidisciplinary rounds. The CTs are reviewed to see if there's any BPA treatable disease, and exclude that the patients would go for surgery with a pulmonary endarterectomy. Then we bring the patients in here for a pulmonary angiogram and a right heart catheterization to assess for the pulmonary pressures. And we want to confirm the diagnosis at this time, plan for the angles of angioplasty in the IR suite. And during this first initial procedure, it's really important to assess the patient and assess their ability to tolerate BPA. As you can see laid out here, BPA, depending on your mean pulmonary arterial pressure, you may have 2 segments per session treated or 1, and these are booked as 4 to 6 sessions in total. So these patients have to continually come back for more treatments, and not all patients are able to tolerate laying flat, coming in for all these treatments. And by bringing them in for this initial pulmonary angio, aside from the sort of technical perspective, it's a really good opportunity to have realistic conversations with the patient and gauge where they're at for their ability to actually go through with the full treatment. It's important to note that all of these patients, due to their history of pulmonary emboli, are on anticoagulation, and they remain on anticoagulation throughout this treatment. So I'll go through a quick case example here. Let's see if this video will work. There we go. So this is a male in his 50s, ongoing dyspnea, and patient has evidence of CTEPH on CTPA with mean pulmonary pressures in the 40s. So I'll just play that one more time for everybody so we can see decreased flow distally here. I'll put back on presenter mode. Oh, sorry about that. That video wasn't working. Okay. All right. Okay. So here we go. We have reduced peripheral filling that we saw in that video, pruning of the vessels here, slow flow overall, reduced venous return, intrapulmonary artery collaterals, and then bronchial artery collaterals that we also could see on the CTPA. So with that, I'll just move a little bit into specific lesions that we would see on our angiographic imaging and the classification for lesion morphology. So here we have in classification A, the ring-like morphology. You can see this very focal narrowing. And then we often see webs as well here as this linear kind of white line through the dark contrast. And then there's also subtotal lesions where they're, partially occluded, but you see only a trace of flow distally, total occlusions, and then these very abnormal tortuous lesions. And I'll pass it over to Dr. Warren to continue talking about CTEPH therapies and BPA.
Yeah, so today you might be thinking like BPA is the only treatment for CTEPH, but the reality is it's a multidisciplinary team, and depending on the level of disease, the patient might go to surgery, might get BPA alone, might be only a medical candidate, or maybe a combination of all three. Because the reality is that surgery is very good at the proximal disease, lobar disease, and extending into the segmental arteries, depending on the skill of the surgeon at your institution. But BPA is not really designed for like lobar arteries, although we have at our institution occasionally treated, disease involving the lobar arteries in highly specific cases. So kind of move, next slide, sorry. So what is BPA? Ultimately, it's applying the general IR skill set to the pulmonary vasculature. It's identifying lesions, crossing the lesion, ballooning it open, as we do in the leg or elsewhere. Next slide, please. So here we're about to do a procedure on this patient. We've crossed a lesion. We see that we've got a sheath, we've got the guide cath, we've got our glide wire advantage through the lesion with a balloon on it. You can see those two dots. And we see that there's a severe stenosis in this lower lobe pulmonary artery. This is the same patient that had that planning angiogram. So we're doing this angiogram to show, number one, we're across the lesion and interluminal. Number two, there's definitely disease here. And number three, that it's safe to proceed with angioplasty. So that next slide, if you don't mind. So angioplasty is performed, and then you can see now that there's a marked return to the level of the periphery of the lung. We've restored flow in what are essentially hibernating vessels. And then you can also notice here on the last image even that the venous return has increased. And so these are the things we're looking for, not angiographic perfection, but noticing that like there's a marked increase in the flow and venous return. Because next slide. Unfortunately, we're not getting rid of the disease. We're just moving it off to the sides. And the hope is that just like the remodeling that led to CTEPH, we can have remodeling that leads to increased flow and ultimately drops their pulmonary pressures and results in improvement for the patient. Can we move forward? Thanks. So like any procedure, there are complications. Hemoptysis is the most common. You could have a guide wire injury, perforation, pulmonary artery rupture, and reperfusion pulmonary edema. So this is largely something of the past where people used to be very aggressive. And if you look at some of the old literature for BPA, pulmonary edema was quite common, but now much less so. Kind of referencing back to what Alanna was talking about, we determine how many segments we can treat based off the pulmonary pressure, and we do a short-term follow-up x-ray that same day, and the patient remains admitted. Next slide. However, occasionally, complications do occur. So here you can see we're doing that check angiogram. Proximally, maybe the wire looks okay, but now in retrospect, the wire is not really following distally the trajectory of the other vessels. Angioplasty was performed nonetheless, as you can see on the right. And then we do our run post angioplasty. And then you see here that there's a large pseudoaneurysm. So there's been a rupture, a wire perforation, which has now been dilated with a balloon. And so thankfully, the way we do this is we use a guide cath, a 7 French guide cath. And so through the TUI, you can put in a microcatheter quickly. We reinflate the balloon to block off the hole, and then we shot in some Nestor coils. So, and then can we go to the next slide? So what's the data to support BPA? I saw kind of mentioned in the chat, there's two RCTs, MR-BPA and the RACE trial. But this is a meta-analysis that was performed in 2022 by our institution. And ultimately, we do two things. So we can improve hemodynamic parameters, but we also improve functional class. Next slide. So, we can drop the pulmonary pressure as a surrogate for everything by about 13, which we also see, improvement in the cardiac index, cardiac output. And then we also can increase functional class by about 1, which, to kind of give you an idea, is maybe about a 70-meter improvement in distance. So like Alanna said earlier, we're not turning people into super athletes. We're really just hoping to get people, able to go out for a walk with their grandkids, make it out to the grocery store, those sorts of things, because a lot of these people these patients are quite disabled. So next slide. Yeah, so to summarize, PE is a source of acute mortality. CTEPH happens when multiple PEs occur and causes debilitating dyspnea. BPA is one of the treatment methods for CTEPH, but it's multidisciplinary discussion, and these are complex patients. But it is a serious disease and can have serious complications.
Dr. Warren, Dr. Supersad, thank you so much for your presentation. We really appreciate what you have to say. We do have some questions in the chat. I'm gonna go find our first one here. If you can give me one moment.
So how do you know it's safe and won't rupture or bleed? Yeah, so we showed that. I think that was said before, that picture. And I mean, the group here has changed over the years. I think there's a lot of learning through experience, and so that's why we do a lot of checks. We see how the wire moves, the freedom of the wire. Does it make sense? Is it following the trajectory of the vessel? That case of rupture is from the early Toronto experience. Thankfully, touch wood, we haven't had anything like that as of late. Regards to pressure wires, so the cardiology space is using this is done by cardiology as well. In the US, there's a lot of cardiologists doing this. I think it's predominantly cardiology, except for out west. But in Canada, it's IR, mostly at U of T, UHN, and we don't use pressure wires. We just we found that the glide wire advantage, the 014 glide wire advantage, is the best working wire. We've tried other wires, and then in terms of pressure wires, so I don't know, it's a cardiology thing. We're not super keen on getting into it. And my understanding is that working over it can be a bit challenging, and I think you have to exchange as well. But to be honest, we don't have a lot of familiarity with it, and we don't have access to it.
Are you using the 014 glide wire advantage track? The track support?
014 glide wire advantage. I don't know. Does it have track at the end or no? I don't know.
Is
there a difference between?
The track is a little bit more support, and the standard doesn't. So
I think we're just using the standard. I don't even. It's it's hydrophilic dystole with pretty. Yeah. That's what we're using. And I mean, the reality is we're working over the tip. You're not burying the rest of the wire. You're just using the pushability of the solid proximal aspect to get through, but you're ballooning over basically the tip of the wire.
And just angiographically, to me, it seemed a bit confusing on the standard pulmonary angiogram. Are you basing it on the CTP? Are you using the CTPA as a guide to go, it's going to be this segment, and this is where I'm going to go with the obliquities, et cetera? And then
so planning has changed a lot. So I've been involved now for a year and a half, and our equipment has upgraded a lot while I've been here, and I've worked on kind of the planning algorithm a lot. And so we unfortunately didn't have access to even cone beam CT a year ago. So we were doing it all off of the CT pulmonary angiogram and planning everything from that. But now our new angiographic equipment is a lot better, and now we're able to kind of do fusion and all these things. But the reality is most of it's just planned off the CTPA. Doing a lot of reconstructions, double obliquities, those sorts of things, and yeah.
And then,
And so I would say when we go in to do like a session, so like patients often book for like 4 to 6 sessions. So each session will have like a target and then like extras, if that makes sense. So like we'll be like, okay, there was like a really good lesion, right lower lobe, medial segment, and lateral segment. And we're okay, those are our targets. These are our angles that we're definitely going to do. And then kind of when you're in the area, you look for other stuff and you kind of treat, as you see it. But like that's kind of how it works. And that seems to be how a lot of the cardiologists are also doing it. Yeah.
And then once you so you get the wire down, which you think is the vessel, in a CTO or a very tight thing, do you advance what balloon are you using? Like a 2 millimeter, like a coronary balloon or a coyote balloon or something too short? Or?
Yeah, so coronary NC Trek is what we're using. Short balloons, short and small, so 2.5, 3, rarely like up to 4 or 5. For like, occasionally we'll do like the interlobar in severe cases, but usually like most of the work is done with 2 and 3 millimeter balloons. And it's actually pretty impressive because like even once you've crossed through the lesion, often if it's like a CTO, you do that check run and already the flow is like dramatically improved, and it's just from coring because we'll push the balloon through, then we do the check and you can just see it's already improved, and then you balloon it and it's like remarkable.
And is it kind of semi-compliant balloons or non-compliant, and how high pressure?
Non-compliant. Yeah.
So non-compliant. How high will you go on these non-compliant balloons? Say it's a
very like we're like low pressure. Like the Dr. Maffeld, who's the one who supported us in this and who does most of it now. Like Dr. Tan does, a chunk, but Maffeld's like the primary one. It's very gentle inflations, like frequent checking, and then we do like a lot of like other stuff. So like snow plowing, so inflating it to a low pressure and then just advancing it forward and backward over the wire to really disrupt the webs. And it's kind of crazy. Like you'll look and like it looks like the lesion has only minimally improved, but the flow will be dramatically improved. And then they'll come back for their pressures after you're done all the sessions and it's dropped by like 15, and you're like, it's phenomenal.
Wow. Well, any other questions from the group? I mean, that's very exciting. I think it's a space that we should all get involved in if we're doing PE, DVT, VTE, and this is kind of the chronic phase, the kind of end organ, end stage population that we can really dramatically improve their quality of life. And I think Dr. Supersad is going to be helping us potentially with the techniques, and so that we can kind of gather data not only from the US, but from Canada and others, both the medical management and the interventional tips and tricks that to keep our patients safe as we incorporate this into our algorithm. But thank you so much. Anyone else have any questions?
No, we can squeeze one last question in. Dr. V, I know we had a question from Dr. Shakya regarding deciding which lesions to treat first when you're performing a staged angioplasty. So, and what's your decision-making algorithm on that?
Blair, feel free to hop in and add on to this, but you really want to treat safely first. So thinking back to that classification system I showed with, like webs and full occlusions and whatnot. So things like the big, abnormal tortuous vessels are much more high risk of having a rupture or complications. So you really want to start with what would be, a good target, like relatively easy to get to, relatively lower risk. And honestly, sometimes when you're in the procedure, I know Dr. V, you asked about like how we do our planning. We do obviously look and plan on our initial CTPA, but then once you're in there, it's really quite amazing. Some of the lesions that are not well seen that like even to the trained eye, you wouldn't call on a CTPA. So once you get in there and do your initial run, if you see something that's like kind of low-lying fruit, that's like a nice little web and a very, relatively easy non-tortuous vessel to get to, start with that and then kind of work within the vicinity. So in one session, if you're doing like left lower, you wouldn't then like jump left lower and then try right lower and then try something else. You kind of stick within that segment. So if you're, honestly, if you're planning right lower first, but you happen to pop into left first, you might just take a look and start there. But the general principle is to start with like the safest lesions first, see how the patient does. There might be cases where you do the first 3 sessions, patient's feeling great, pressures have come down quite a bit. And, based on discussion with the patient and the team, you might not do the next sessions rather than go on to just, unsafe lesions to treat. Dr. Warren, did you have anything to add?
Yeah, safety first. Generally, we don't treat both lungs in the same day. Because if something were to go bad, both sides, like it's not good. And you want to think too about like amount of lung that you're perfusing. So, some tiny like upper lobe apical thing that looks really juicy, but has a very small amount of lung, maybe not worth going for. So just kind of like basics of perfusion and those sorts of things, like